It is my pleasure now to introduce someone you already met. Dr. Allison Baker was on our panel yesterday. She's going to talk to us about ADHD in midlife women, perimenopause, menopause, and the clinical frontline. Dr. Baker, as a reminder, received her MD from the University of Virginia and completed her residency in general psychiatry at Columbia University, serving as chief resident. She completed her child and adolescent psychiatry training through the combined Columbia-Cornell program at NY Presbyterian Hospital, and then worked at the Child Mind Institute in NYC prior to moving to Boston. She's a clinician educator at Massachusetts General Hospital and Harvard Medical School and has a private practice for general psychiatry. Her clinical interests include perinatal psychiatry, child psychiatry, and she served as the MCPAP consultant to primary care providers. She has a special interest in ADHD across the reproductive lifespan and has piloted the first study investigating the course of ADHD in pregnancy. Dr. Baker is dedicated to bridging developmental, reproductive, and psychiatric care for children, adolescents, and families. Please welcome Dr. Baker.
Thank you for that warm introduction, and it's great to be back up here this afternoon. I'm delighted to follow my wonderful colleague, Dr. Ruta Nonax, and good friend, and the sessions are stacked nicely to really do a deep dive into psychiatry at WHAM. So I hope that this will be familiar in some respects in terms of some of the overlap with many of the treatments in terms of mood, anxiety, and then in this case, ADHD needs during the perimenopausal and menopausal transition. I have no disclosures. This session is about making sense of a very common but often confusing presentation, and Ruta and I were having a bit of a laugh that this is complex and a little bit messy, sometimes in terms of really teasing apart a complex clinical picture when patients present for consultation. We all know that midlife women, as they present, will often have a chief complaint of not feeling like themselves, feeling newly scattered, feeling overwhelmed, reporting that they are more forgetful, or not functioning like they used to. Where ADHD, menopause, sleep, and mood all overlap, this is where I hope that we can spend some time together and tease it apart as best we can. So one learning objective for you all this afternoon is to recognize the impact of perimenopause and menopause on executive functioning. We know that fluctuating and then ultimately declining estrogen and progesterone levels can affect attention, working memory, executive functioning, and emotional regulation. For women with ADHD, symptoms often worsen. For others, vulnerabilities may actually surface for the first time in their lives. A second learning objective is to differentiate what you can. ADHD typically has a lifelong pattern, even if it was masked, and I alluded to this yesterday on the panel. Many women will reflect on a longitudinal pattern, even if they've never received a formal diagnosis or treatment until the midlife. Whereas menopause-related cognitive changes, as we also discussed yesterday, tend to represent a shift from baseline and often track with other co-occurring experiences, for example, sleep disruption, vasomotor symptoms, and mood changes. That said, many patients have both, which is where the messy part comes in terms of teasing apart what's what. Third, I'd like us to understand the evidence base, even though it's pretty limited for this particular topic. There is growing, but still limited, and sometimes conflicting research on ADHD and reproductive aging, so that adds to the complexity. And this is where your clinical judgment really comes in and is essential and will serve our patients well while we await a more robust evidence base. And then a fourth learning objective is really to screen with intention. When women are presenting with, quote, brain fog or anxiety or burnout, one question that you can ask is, has this always been there? Were there earlier signs? Things like disorganization, procrastination, emotional reactivity that were historically compensated for, and a woman is no longer able to do so. Why this is not a niche issue is because the reality is that women remain underdiagnosed with ADHD across the lifespan, and that often this is the first time that this potential diagnosis is coming to the clinical fore and to clinical attention. We know that perimenopause and also menopausal transition is a peak time for a lot of co-occurring psychiatric vulnerabilities like insomnia, anxiety, mood lability, as well as the more cognitive challenges in executive functioning, dysregulation, or brain fog. And in primary care, many of you are often the first and frankly only clinician that women are presenting to. Just quickly by way of background, because I know this is a WAM conference, and in adult psychiatry residency, we don't often get that much training on ADHD, so wanted to bring everybody up to speed in terms of what it is. It's a neurodevelopmental disorder that is brain-based and characterized by levels of inattention and/or hyperactivity and impulsivity that are greater than what you would expect from a person's age or developmental level. So for example, think about it in the developmental continuum. Are these symptoms and challenges similar or more pronounced than their contemporary? The tricky bit also gets into ADHD and how it presents differently in women, and I'll touch on that on the next slide. But wanted to include, for completion's sake, the inattention and hyperactivity and impulsivity criteria here for you to be able to reference moving forward. We know that about 4% of adults have ADHD, and of these adults, 38% are women. So roughly 1 in 30 women has ADHD. We also know that this is linked to many important health comorbidities: poor general and mental health, increased rates of substance use disorders, impairment in occupational domains, and financial distress, as well as strong association with other mental health disorders, for example, mood and anxiety disorders. This is the slide I was referring to in terms of how ADHD in women often looks different than the more classic externalizing picture that we are taught in our clinical training. It is more likely to show up as internalized symptoms, and so what does that look like in the clinic setting? Women complaining of feeling overwhelmed, disorganized, having challenges with emotion regulation, and a lot of self-doubt. These are much more commonly reported symptoms than the overt hyperactivity. Hormonal transitions are also an inflection point. During the perinatal period and also during the perimenopausal transition, we will see the shifts in estrogen and progesterone and ultimately decline in both can meaningfully affect attention, mood, and executive functioning. And for some women, as I said, referenced earlier, ADHD symptoms worsen, but for others, these long-standing vulnerabilities that were actually always there become newly visible or present for the first time to clinical attention. This is where the diagnostic gap really comes from in terms of girls and women with ADHD being less likely to present with overt hyperactivity and more likely to be struggling with inattention. As I said, things like forgetfulness, cognitive overload, anxiety, overwhelm. And these are much easier not only to miss, but also to misattribute. Many women, as I've come to learn in clinic over the years, become incredibly skilled at masking their symptoms. They overcompensate through perfectionism, overachievement, or sheer effort, which can delay recognition for years, even decades. And you can really appreciate how that is often ultimately no longer feasible in terms of that sheer effort when you have a newborn or you are in your midlife at the height of your career and managing aging parents and school-aged or college-bound children. That is the proverbial straw. And then, of course, there's comorbidity. So anxiety, depression, PTSD, and eating disorders are incredibly common in terms of co-occurring, and often actually what bring women into care ADHD is often missed entirely or treated as secondary, when in fact it may be a key underlying driver. And why that's important is because it can allow for an elegant solution in terms of treatment with the fewest amount of medications and other pharmacologic modalities sometimes. These are the downstream consequences of missing ADHD in women. We hear in the clinic reports of chronic shame, many women growing up feeling like they're not living up to their potential, internalizing their struggles as personal failure rather than a neurodevelopmental difference. And then that negative self-concept can really become deeply ingrained. Second, it can look like treatment-resistant depression. So for example, if the underlying executive function vulnerabilities is not addressed, we've seen many women cycle through antidepressant trials with only partial or temporary relief. And so it can look on a chief complaint or chart review as treatment-resistant depression, that she's tried this SSRI and this SSRI, and none is fully treating or optimally treating her overwhelm, her sleep challenges, her negative self-talk, etc. Third, misdiagnosis. We know that ADHD is often conceptualized as anxiety or mood disorder alone, which is not wrong, but it's incomplete. The driver of the impairment may be missed. And finally, burnout is something we see a lot, and especially at this age in terms of cohort of women entering the perimenopausal transition. High functioning, they've been compensating for years, and at some point their systems that they've figured out in terms of pulling it all together stops working, often during periods of increased demand, not only in their caregiver roles or professional roles, but also further made vulnerable by these hormonal transitions. A helpful way to think about ADHD in women is across the lifespan and thinking about all of these hormonal transition points, for example, puberty, certainly the postpartum period, and perimenopause as key times or windows of signal or symptom amplification. These are windows of increased vulnerability for some of the reasons I've already mentioned, and also the specific shifts in hormones can really impact neural circuits that govern attention, mood, and executive functioning. Clinically, many women will describe, and you'll hear this in your clinic, I managed fine until this phase, so how is this possibly ADHD? Whether that's through high school or after having a baby or in their midlife. And importantly, the emerging literature, albeit small, does align with this, consistently showing that women will report worsening of ADHD symptoms during hormonal transitions, particularly in the postpartum and perimenopausally. I've included this thanks to wonderful colleagues at the Duke Center for Girls and Women with ADHD, which is a great reference, and I encourage you to bookmark it because it's got all kinds of very practical screens and summaries with respect to ADHD in girls and women. And this helps the clinician determine whether or not this is somebody who we actually should make a referral for further workup, whether that's for formal neuropsych testing, which, by the way, is not necessary to make a diagnosis of ADHD, but can often be helpful in teasing apart complex presentations. But at the end of the day, this is a clinical diagnosis that can be made in your office. So I've included this here, and also many other great resources in terms of screening, rating scales, and psychoeducational materials for patients and their families. At a neurobiological level, we know that estrogen and progesterone act as neuromodulators, particularly within dopamine and related circuits that are central to ADHD, including, among others, the dorsal striatum and the nucleus accumbens. And we know that estradiol enhances dopamine receptor release and receptor sensitivity, as well as facilitating other neuronal changes, especially in regions where there is supportive executive functioning and habit learning. We also know that progesterone, generally speaking, will amplify these effects. So in short, if you want to think about what is the relationship, The neuromodulators, the hormones, will boost often dopamine availability in attention and reward circuits. And in ADHD, those same striatal circuits are already having a hard time sort of keeping up or functioning. So this contributes to the challenges we see clinically, where women will describe a lot of difficulty regulating attention, with reward processing, with impulse control. So when you layer in fluctuating and then ultimately declining hormonal or neurosteroid levels, you're layering in this hormonal variability onto an already challenged regulatory system, which helps us understand why at these transition points, ADHD symptoms can get louder. Perimenopause really is the perfect storm from a neurocognitive standpoint, because with estrogen no longer being steady, this unpredictable fluctuation and ultimate over time decline, and its tight coupling with dopamine regulation, this does create uncertainty and instability in the circuits that really govern these important areas that show up as ADHD. So specifically distractibility, reduced cognitive stamina, more mood variability. And one part that I really want to underscore, I don't think necessarily about the mood and anxiety vulnerability always as a totally separate and apart silo with respect to ADHD, that there's the executive function and cognitive symptoms over here, and then there's comorbid or co-occurring GAD or MDD, but rather regulation of all of these different domains, including modulation of anxiety and mood and reactivity, all can be governed by these specific neurosteroids. So clinically, as I said, this often shows up as increased distractibility, reduced cognitive stamina, and patients often just complaining of the sense that their brain isn't working the same way. And interestingly, and again, we have a very limited evidence base, so this talk is really anchored in the clinical experience thus far. But there are data to show that stimulants can help women feel less burdened by those symptoms. And conversely, many women who are already on an established ADHD regimen, they may report for the first time that their stimulants actually are feeling less effective, specifically in the late luteal phase or during the perimenopausal transition. So research has shown certain findings. There's not a huge evidence base, as I've said, so I'm sharing here what we know, what the research shows, and what it doesn't. We have some evidence suggesting worsening by self-report studies where women diagnosed with ADHD in one survey, and again, the quality of the data is not the most robust, but will report worsening during the menopausal transition. And approximately 70% reported postpartum worsening. So that sort of that's a theme that we're hearing in terms of in those hormonally sensitive windows, there is roughening of ADHD symptoms. Most premenopausal women will report luteal phase exacerbation. So during the second half or sometimes even the week preceding their menstrual period, their sort of steady Eddie ADHD regimen is no longer quite as effective. I will also add that it's worth checking with respect to their ADHD regimen if they all of a sudden have a different generic manufacturer of their medication, because that has also been something that, with stimulants sometimes being in short supply, a medication will be swapped and it's the same prescription, the same dose, but if you look on the bottle, it's a different generic manufacturer, and some patients have really noted differences between one generic manufacturer and another, even with the same dose. And you can, as a clinician, advocate at the pharmacy for a particular generic manufacturer to be filled if they have it in stock. This was an interesting and somewhat nuanced finding in a population-based study looking at over 600 women. When controlling for age, menopause stage, and medication status, there actually aren't significant differences in terms of menopausal complaints between women with and without ADHD diagnoses. However, across the entire sample, ADHD symptoms do correlate with menopausal complaints. So as ADHD symptoms increase, so do reported menopause-related difficulties. So that correlation, interestingly, is actually weaker within the diagnosed ADHD group. One explanation can be attribution. So for women who have historically carried an ADHD diagnosis, they may be more likely to attribute their symptoms to ADHD, whereas those without a diagnosis may experience and report those symptoms as new or menopausal. And so this is just restating the interpretation of that. Again, small study with a nuanced finding that can be somewhat confusing, but then you anchor it in the clinical lived reality, and I think it helps shed some light that at a group level, while women with ADHD do not appear to experience more severe menopausal symptoms, at an individual level, symptom overlap is substantial. This is a key finding for clinical practice, looking at perimenopausal and surgically postmenopausal women and how they score in terms of executive function challenges. So we can see that when you control for sleep disruption, anxiety, and depression, those differences largely disappear. So this suggests that a significant portion of these cognitive complaints that we're hearing in the clinical setting may actually be more driven by poor sleep, mood, and anxiety, or in some cases misattributed to menopause itself. So this is where the literature gets a bit messy, and it's important to interpret carefully. The bottom line is that we have strong subjective reports and correlational data, but we have limited, at this point, longitudinal, mechanistic, or interventional studies. And we see some real tensions in terms of trying to make sense of the limited evidence base. Women are consistently reporting worsening symptoms, but in a cross-sectional study that doesn't show clear group-level differences. We know that hormones can affect dopamine signaling and dopamine system regulation, but we have, surprisingly, or maybe not so surprisingly, very few studies examining hormones and ADHD together. We see executive dysfunction in perimenopause, but much of that is likely mediated by sleep disruption, as we've heard several times now in these talks, as well as anxiety and mood's contribution to those challenges. And then clinically, many women will report fluctuating stimulant efficacy, but we don't yet have robust randomized data to help guide how exactly we adjust treatment moving forward. So I stand here to reassure you that at the end of the day, as clinicians in the office, that there's a signal. We're still building the science and your clinical judgment, pattern recognition, and first do no harm, but also trying to help as women are presenting with very bona fide needs. There's significant overlap, further adding to the complexity, there's significant overlap between ADHD and perimenopause symptoms, and this was echoed in Dr. Nonox's talk, looking at inattention, working memory challenges, brain fog, sleep disruption, irritability, and emotional reactivity. So diagnostically, where I think the pitfalls lie is sort of threefold risk. The first is that we misdiagnose ADHD as depression or anxiety, or we attribute everything to menopause, or we miss long-standing ADHD that's only becoming visible now. So I think the key really lies in pattern and timeline. And if you take that history, even just with one question, looking for the developmental through line, even if it was masked, whereas perimenopausal symptoms really do tend to represent a change from baseline, and often cluster with other perimenopausal symptoms like sleep changes, sleep challenges, and vasomotor symptoms. So here's a summary slide encouraging you to think about ADHD if a patient is presenting not only with perhaps your bread and butter perimenopausal symptom complaints, but also will describe lifelong history of effort bursts in a procrastination style, or always having a hard time with organizational systems, history of academic underperformance despite intelligence, history of comorbidities, so for example, anxiety and depression since adolescence, so think possibly, but also possibly primary ADHD presenting to clinical attention through the lens of overwhelm because of the anxiety regulation challenges that are part and parcel of this diagnosis. Chronic overwhelm predating perimenopause, and children with ADHD. So we know this is among the most heritable conditions that we treat in psychiatry. And the clinical reality is that I will often see a child in a family system for the diagnosis of ADHD and the treatment, and then subsequent to the child getting tucked in and getting their needs met, the parent will often circle back and say, now that everything's settled over here, I can't help but have thought about my own childhood and my own struggles that have stayed with me into my career, and it's possible that I had it as well, but it was never picked up. There was a 2020 study in the Journal of Clinical Psychiatry that found that ADHD in adults presents in two subtypes. Instead of attentive and rather inattentive and hyperactive, they made a differentiation between emotional versus attentive challenges. And so this research found, or rather the researchers found, that this framework offered a more clinically relevant approach to diagnosing ADHD symptoms in adults than current DSM-5 criteria, which I mentioned in one of the introductory slides, is really based on research conducted on children ages 6 to 12, and historically on boys and men. And so this evidence calls for more research on how ADHD symptoms change and evolve with age, and specifically how emotional dysregulation impacts adults with ADD. Similarly, treatment strategies for adults with ADHD merit further exploration. So stimulant medications are often the first line of treatment for ADHD. There was a study in the Netherlands that was published in the Journal of Attention Disorder that found that older adults with ADHD experienced symptom improvement when taking a low dose of stimulant medication, which was well tolerated and did not cause any clinically significant cardiovascular changes. And finally, gender role expectations complicate ADHD in women. This is something that we hear clinically all the time in terms of society's long list of expectations for women in terms of managing the self, the family, the home, the career, and all of this. If you think about what is required from a cognitive perspective, this is consistent coordination of executive function, and women with ADHD are sometimes not as well wired in terms of meeting these demands, and yet in seeking social acceptance, they are often determined to meet them, typically by masking symptoms and problems, ultimately shaming and self-blaming, which only further fuels this dynamic interplay between societal expectations and ADHD's executive dysfunction. And all of this, I think we cannot underestimate how women measure their self-worth and self-esteem according to whether or not they're able to succeed in these gender expectations. So I just really want to underscore the nuance of that clinically in terms of something to consider as we sit with patients. In terms of practical assessment in the clinical setting, think developmental, and instead of saying, when did this start, you can ask the question anchored in childhood development. Looking back, were these difficulties present in childhood, adolescence, or early adulthood? We do have screening tools. So in addition to the Duke Center for Girls and Women with ADHD, there are other easy-to-use tools. So the Adult ADHD Self-Report Scale, or the ASRS, is free and available in the public domain. It's self-report, so patients can complete that in advance of the visit with you, and walks through symptoms in terms of a checklist that has been validated for ADHD and serves as a helpful jumping-off point for further discussion or referral. As well, there are screening tools that Dr. Nonax mentioned, and I'll just underscore in terms of other psychiatric comorbidities, so the PHQ-9, the GAD-7, and sleep assessment. Always important, I know I'm preaching to the choir, to assess the hormonal context in terms of where our patients are with respect to menopausal transition, menstrual cycle tracking, MHT use, and also surgical versus natural menopause. And then to think about the treatment considerations. And so this is a busy slide, but again, I've put it here so that you can reference it at a later point as a practical step-by-step treatment framework. And again, not because treatment is ever perfectly linear, but to help drive these key points home in terms of an easy reference to come back to after the conference. So when these patients present, clarify the history. We're looking for lifelong pattern. Then we want to know what has changed versus what may have always been there. Then think about major contributors, so sleep disruption, anxiety, depression, hormonal transition, and executive dysfunction itself, because in many or most patients, these are layered rather than totally crisp and separate. And from there, treat the most modifiable pieces first, so optimizing sleep, address mood and anxiety, considering the hormonal context and MHT if appropriate, and then build behavioral and environmental supports. So if ADHD still remains part of the picture, this is where I would consider targeted treatments, so whether that's psychoeducation, good coaching. For example, cognitive behavioral therapy for ADHD is an evidence-based intervention, organizational strategies, externalizing of your calendar, body doubling, medication, and in all likelihood, a combination of all of the above. And then finally, to reassess. So once the picture often becomes clearer once the loudest overlapping contributors are addressed. Many women experience vasomotor symptoms, night sweats, sleep disruption, and mood changes, and related distress. And so in addition to MHT, this is a review of certain psychiatric medications that have an evidence base. This is almost word for word a slide that was in Dr. Nonax's talk as well. We are work colleagues, and she's one of my best teachers, so including this here for completion. How to distinguish ADHD from common midlife psychiatric symptoms. As I've stated, many midlife women often present with overlapping comorbidities and complaints. So before assuming ADHD or referring to psychiatry, we can consider and treat these common, well-characterized psychiatric conditions that may either masquerade as or amplify ADHD-like symptoms. So where low mood and anhedonia is the symptom cluster, maybe that's major depressive disorder, persistent worry, can be addressed through the lens and treatments of generalized anxiety disorder, and so on and so forth. In terms of what is reasonable to treat in the primary care setting or the non-psychiatric setting before a psychiatric referral, because I recognize that it can mean long wait times for a referral to take place. There are many first-line treatments that are appropriate to initiate in terms of these common contributors to distress and cognitive complaints in our patients. And again, this is a lot of what Dr. Nonax's talk covered, but very reasonable and low risk to consider SSRIs and SNRIs for mood vulnerability, while also recognizing overlapping symptoms with the perimenopause. So for example, sleep and energy and concentration. Again, these class of medications are effective and low risk for the treatment of anxiety disorders, as well as excellent evidence-based psychotherapies that can be short-term and pretty targeted. CBTI for insomnia, as well as great sleep hygiene. I loved that question about screens. I agree it's clinically an incredibly challenging reality to contend with. And then whatever sleep-related vasomotor burden is contributing, you can consider non-psychiatric hormonal options, or rather the gabapentinoids are reasonable to consider for sleep and also vasomotor symptoms, as well as then the hormonal context. How about when to refer to psychiatry? I think it's always appropriate if there's diagnostic uncertainty. We have a saying clinically as a group, never worry alone. So if you're worried about a patient or it's complex or you're just uncertain in terms of what is the diagnosis and what's the appropriate next step, we welcome those consultations and referrals. Certainly treatment-resistant cases where you've really made multiple interventions that have not really changed the game or certainly made the clinical context more confusing or worse in terms of our patient's experience. That's a reasonable consultation. And of course, the complex comorbidities, so psychiatric diagnoses like a bipolar diathesis, substance use co-occurring disorders, suicidality, or severe functional decline. This is a slide just to represent the multimodal treatment of ADHD in midlife. I borrowed the framework from groundbreaking studies in child psychiatry that are decades old, looking at multimodal treatment for childhood ADHD, and adapted it for what are the modalities, the treatment interventions that we have, where there's